I'm Larry Boris, the Executive Director of the National Association of Worksite Health Centers. I want to thank everyone for joining us today. This is our one of a series of our webinars on organizational issues relating to worksite health centers. Today's topic is different payment structures. Many employers are uncertain about the options that they have to when they contract with a health center sponsor, health center provider, or a third-party vendor, clinic vendor, about the different options they have for contracting and what should be in the contracting. And so I'm pleased to have today Stephanie Erkely from Craig Duvall and Mike LaPenna from LaPenna Group, who will be presenting their information and details. Copies of the slides and the recording will be available to those who participate and on the NAWHC website. For those of you who are not members of the organization, just a little background. NAWHC, or NOWIC, is the nation's only nonprofit group focusing on on-site, near-site, mobile, virtual health and wellness centers. We are an organization that assists employers in developing and expanding those centers, as well as helping the vendor community and providers and others in understanding what purchasers need and helping them understand what they can do to improve the services that they deliver. We offer a variety of educational programs such as this one, networking, benchmarking, and other opportunities. We have two upcoming major events: our annual forum on September 9th. That should be 9th and 10th, not 9th and 20th. It's not that long of a meeting, but it is 9th and 10th, and it is in person in Chicago. So please plan to attend. It'll be a first time for many of us to get together face to face. And then later on in the year, we've got another session on operational issues on medical records and the importance of those and the different kinds on October 18th. That'll be, again, a webinar. So we look forward to seeing you there and hoping you'll participate. At this time, I'm going to turn the program over to Stephanie and to Michael for their information. So Stephanie, turn it over to you.
Hi, well, Larry, thank you. Really excited to be here again today on behalf of National Association of Worksite Health Centers, and hopefully everyone can hear me. If there's any issues, Mike or Larry, with that, just let me know. So today we're going to get into the weeds on payment issues and payment structures. But before we do that, we wanted to highlight a recent case study that came out. This was published by JAMA on April 20th. And it is a comparison of employer-sponsored cost versus community-based primary care. And we thought this would be an interesting case study to start with because it talked about the actual cost for this national employer, as well as some of the metrics and utilization rates, which really tie into what we'll be dealing with today. So this case study involved a engineering and manufacturing firm in LA in the aerospace industry. And they had one on-site clinic in LA, 15 near-site clinics near other company locations all over the US. And then they also provided virtual care through a platform that could be accessed both on the cell phone, mobile, or on the web. The services included integrated primary care, mental health services, and physical therapy. So in this case study, they used insurance claims data as well as other data, and they reviewed services from 2016 to 2019 over about 23,000 commercially insured employees. The services here were available to both employees and dependents. And so here's where the the data starts getting interesting. And I know when I finish up talking about this case study, Mike has studied it too and has some thoughts to share. But here they said that 22% of eligible members use the employer-sponsored services. So, if you think about the entire population, not a huge number, but still pretty good here. And they also looked at the cost to the employee. So here it was no charge for on-site and virtual care, but then a $25 copay for near-site clinics. And employees with high deductible health plans had a $1,500 individual deductible to comply with the terms of that plan. And the study showed that the employer-sponsored services cost about a mean of $87 per member per month after infrastructure and service costs, which I thought was interesting. So, that's not the all-in cost there. And the results of this were, of the members using the model, they had higher primary care costs and mental health services, but they had a lower spend on emergency department or emergency room visits and hospital visits. And so the study showed that the utilization of the on-site clinic model, or really the employer-sponsored health model, since there was also near-site and virtual, had an overall lower total healthcare cost for those individuals that participated. But one thing I thought was interesting is with any study, it's, you ask why. And so one point the study made was whether the total healthcare cost was attributed to the use of the primary care clinic and employer-sponsored services, or was it, because the individuals using the clinic through self-selection were already at lower risk for health issues, or some combination of both. And so I thought that kind of was a nice baseline just to open the presentation with, to show, a real life model of utilization and cost. And this can be found on the NAWHC website as a resource in the members only section if you really wanted to get into the nitty gritty details. And there's a lot of detail on cost and pricing in that study. Mike, did you have any thoughts on that study or comments as we jump in here?
Only that I urge everybody to read it because it's an interesting study, but it is kind of unique in that it's LA, it's some parts of their national group. This is SpaceX. It's One Medical. If people are familiar with One Medical and the way that they deliver care, it's a very, very sophisticated primary care model. And note the lower spend on emergency department and hospital visits. Those are metrics that are very easy to compare person to person, site to site, et cetera, and a great metric to look at. I think it's also noted that the infrastructure costs are not included. Depends on how long you amortize those infrastructure costs to understand whether or not there's a true cost savings here. So I think it's great lead in. Pricing is everything. And if you've got to understand how pricing works and how you might fashion guarantees, you would look at this and say, can I get lower total healthcare costs by some metric? Spend on emergency department and spend on hospital visits are two great metrics. So thanks very much for the opportunity to comment.
Thanks, Mike. And that was a really great lead into the next slide, Mike. So before we even get into the nuts and bolts of pricing, you really have to understand your baseline metrics. And when I say baseline metrics, these are things that a company should look at prior to even negotiating or thinking about the price. And I know on the legal side, when I'm negotiating contracts and we get into pricing, it's like, okay, we can talk all day about what we think, the reduction in the ED visits will be and the hospitalization, but you've got to know your company first. And so just some basic questions that we always encourage clients to work through, and I know Mike does too, is, what is your company's overall spend on healthcare? Have that in your back pocket. Know what that is before you even go down the road of not just negotiating price, but determining whether you're going to get an on-site clinic. Where are you spending the most money? Is it hospitalization? Is it ED? Is it your chronic, your diabetic employees? What are you guys doing right? If you already have a great telehealth platform with high utilization, or you have great mental health services, maybe that's something you don't need to reinvent the wheel with a new contractor, but you figure out how to integrate that. Similarly, what needs to change? But I think really critical is, are your employees engaged in their own health? And so, as we saw with the SpaceX one, utilization is everything there. That had about a 22% utilization rate. So if you already have a population where you've worked to get engaged, even before getting the on-site clinic at your location, utilization may come a lot easier. So just that planning and prepping is really critical there before you get into even the pricing. So again, more on the due diligence side, before we get into pricing again, you need to think about what role will the on-site or near-site clinic play. So for example, will they be doing primary care versus occupational health? Very, very different pricing structures and metrics and guarantees that you're going to look at if you're doing one or the other, or if you're in a clinic that does both, which is not quite as usual, but we do see sometimes. Another big one, will it be employees only, or will you also be including dependents? Again, big impact on pricing and utilization potentially. And then is it an add-on to other healthcare services? So will you maybe be contracting with just a near-site clinic, but also have your very traditional community-based care, fee-for-service model that your employees can use and are encouraged to use? Or will it be a true, on-site health clinic that is the medical home for your employees, or at least that's where you want to end up? And then what type of vendor are you contracting with? And so again, I think you have to understand the different types of vendors, because there are definite trends you see among vendors with pricing. And so you may have your traditional on-site clinics. So these are, the ones that you think of that are kind of the big players nationally and also regionally that have the on-site clinics. You may see with them sometimes more of a PEPM or PMP, per member per month model, which Mike will get into those in a lot more detail. The next one we're seeing, at least here in Indiana where I'm located and in the Midwest, I think more of an uptick in, or at least health systems trying to get more involved. You'll see the health systems. We are seeing a lot more local county hospitals try to get involved in this, but also a lot of the really, really big regional and national systems. So what I've seen is more of, you'll see some traditional pricing there, but also a lot of those health systems are so, the mindset of traditional fee for service, and also making sure that their services are fair market value and comply with the anti-kickback statute, that sometimes you may see a little less flexibility depending on the health system to think outside the box as far as pricing. We also see independent physicians, your telehealth providers, and then specialty services. And again, I think with telehealth, that's all over the place. Specialty, though, I think, again, it's much more of a traditional fee-for-service model there, but you will see some more per employee per month or per member per month and guarantees and risk. And some of them, like I've seen it with physical therapy, chiropractors, and certain wellness services.
Stephanie, if I could, I'd only reflect on the fact that the traditional vendor partner that has been in the business for a while, 10 years, 5 years, perhaps even linked up through a venture capital connection, they're going to have less flexibility because they've based a business model on their pricing structure. A health system that's brand new may have more flexibility because they don't have a traditional orientation to a pricing structure. And this may be their opportunity to branch out a little bit and capture some commercial business. Commercial business to a health system is extraordinarily important. And the rest, all over the map. There's no one model for independent physicians or telehealth. I have no idea how telehealth is pricing from one group to another. Specialty services, of course, that depends. Is it obstetrics or is it orthopedics? Very different models because they have very different services.
Yeah, and Mike, such a good point on the health system too. We do see with some of the smaller county hospitals that are doing that they're willing to be more flexible, especially as they're trying to have a new service line that's not dependent on Medicare and Medicaid and not dependent on inpatient procedures, especially after we saw, how much that fluctuated from COVID. And so I would say whether you're, if you're a county hospital on the line that's rolling this out, or you're an employer that may be negotiating with the hospital, have those conversations about whether creative pricing is available. And if you're an employer too, I would really do your research, and we'll get to some other resources that are on the NAWHC website, but do your research where you're coming prepared with different models that might work for your population and your finances and everything too, especially when talking to those newer providers. So we're going to talk just a little bit about contract terms that impact pricing. Mike will touch on more like I said, the PEPM and some of the actual like core pricing models, but I think there's other things even before then that we need to think about when you're looking at pricing. So in addition to just the monthly amount you may pay for a member per month, you're going to have a lot of other things. One is the capital investment and construction fees. So for a lot of the clinics, it's a beautiful facility. It really feels like you're walking into a wellness clinic. I've been in some that, you almost feel like you're in a spa-like setting when you walk in, and it is nothing like the rest of the employer's building, even if it's within it or attached. And so one thing you're thinking about is, what are those construction fees? What is that capital investment? And who's making that? Is the employer obtaining financing for that? Or is it something that the on-site vendor is going to bear the cost of? And how is that allocated? The ownership of the assets and intellectual property is another big one, and one that can be up for negotiation and can impact pricing. The contract term. So this is one that we get into a lot when we're negotiating. So a lot of times you'll see, at least in my experience, the providers, on-site clinic vendors, and even some of the kind of ancillary providers want to have a longer guaranteed contract term, whether it's 2, 3, 4 years, right? Where maybe the employer does not have the ability to terminate without cause because they want that annual recurring revenue stream once you get past that capital investment and construction fees. So we have seen in some cases where, there may be more of a willingness to negotiate fees if there's a longer guaranteed contract term as opposed to a shorter one where they cannot have, the projections on that annual recurring revenue as a guarantee. And so that's a really big one too to think about, but also to think about from the employer's perspective, what you're comfortable with. Guarantees, Mike's going to talk a lot more about that. That will absolutely impact pricing when you're negotiating the contract. Metrics. The pharmacy spend, that's another big one. And I think this one can be a bit of a black box sometimes. I would just really encourage employers to sit down and understand all the pricing when it comes to pharmacy. So if you're working with a third-party provider that does the, dispensing for you and delivers the drugs and the prepackaged bottles, understand how they're pricing. Is it at cost? Is it a cost plus, as in the clinic provider is putting a percentage on that cost? Is there a rebate system in place? And is the rebate system transparent? How is that done with the pharmacy vendor or with the on-site clinic vendor that may be contracting with the pharmacy vendor? And one thing we'll get into here is really knowing and having control over subcontractors that your on-site clinic vendor may utilize. Some employers really want that control. They want to be knowledgeable about it. I've seen others where they just want the on-site clinic vendor to handle all that, right? Handle all.
Has to make a long-term, someone has to make a long-term investment, and then some vendor provider partner is making a shorter term commitment. But wherever the capital investment and construction fees fall, that has to be long-term. That's where the longer-term contracts come in, or the very complex unwinds. In most cases, the employers who are having the on-site clinic on-site will have space available, and they'll perceive that to be a no-cost part of the program. It's really not no cost, but in any cases, it has to fall someplace. When it's a longer term contract, there's more opportunity to amortize that initial capital investment and construction.
Thanks, Mike. I feel like I keep talking about due diligence here and thinking how you want to structure everything. But one of the really big variables we see, among on-site clinic providers, among the health systems that are doing this contractually, is staffing and the impact that has in pricing. And so, you know, there are so many different ways you can staff an on-site or near-site clinic now, especially when you add in the virtual care component. And some of the staffing will be driven, of course, by state law, right? Both a scope of practice and a pharmaceutical dispensing scope of practice there, whether, you know, the MDs can dispense on site or the NPs or the PAs, or whether you need to have a licensed pharmacy. Most states do allow dispensing, but there's some pretty significant exceptions there with just a couple of states. Of course, one of the most expensive models will be having the MD on site full time. But with that being said, we see a lot of employers that do prefer that model. And I know I work with some vendors that is their preferred model. We also see, you know, almost in all cases, almost all, the medical doctor or physician involved in some way. So even if they're not on site full time, they will be a supervisory or a collaborative MD for the nurse practitioner or physician assistant. And this will still be at some cost, but much less than having the medical doctor on site full time. Sometimes you also see a medical doctor in a medical director role for that on-site clinic, but then you'll still have the NPs and PAs. So we just talked about the NPs and PAs. In those states that are allowing nurse practitioners a full scope of authority, basically without having any oversight or very, very minimal oversight, we are seeing a large uptick in nurse practitioners in those states where they can practice independently, because it is such a cost savings for the vendor and the on-site or the employer. Of course, then you're going to have your RNs and your licensed practical nurses and your medical assistants. And we definitely see kind of a pull here as far as, you know, employers and vendors want to push everything down to the lowest possible denominator from a licensure perspective, because it will be more cost efficient. But you also have to think about the scope of practice, ability to be at the clinic alone, expertise, continuity of care, and those issues. And then don't forget your receptionist, you know, your administrative staff. And then lastly, cost of overtime and weekend hours. I was working on one negotiation and the price was X, everyone was there, and then they decided to have Saturday hours, and there was kind of a miscommunication there about the differential in having regular hours versus having a provider on site for the Saturday hours. And so, you know, we worked through it. But again, just understanding and thinking about that from the beginning would have saved a little bit of heartburn when we were very, very close to finalizing the contract. I want to spend just a few minutes, and I bet Mike is going to have some good input here, on both return of investment and the value of investment. So I have to give the next few slides really credit to the NAWHC guidebook for measuring the performance of worksite health and wellness centers. That, again, is a resource that is available on the member-only part of the NAWHC website. And, you know, in preparing for this presentation, I really dug into that book again, which I hadn't looked at for a few months. And it is such a valuable resource if you are getting ready to go into contract negotiations. Really, whether you're on the vendor side or the employer side, it's just got a lot of like very detailed information about metrics and guarantees and what you should be expecting, and it's kind of standard practice now for all of that. So one interesting point that it talked about the return on investment versus the value of your investment. So when measuring ROI, you know, these are some of the things that it talked about. I won't go through all these, but, you know, employee engagement measures and productivity measures, cost measures, and really how do you get to even having the right information to measure the ROI, which ultimately will impact pricing. And it was interesting, Mercer and NAWHC did a study in 2018. It's the 2018 survey report. And that study said that slightly more than half of respondents, so 54%, have not even attempted to measure return on investment because, you know, it's just such a challenge to have objective methodology and data aggregation to get there. So I think we've definitely come a long way since 2018 on the data, but it would be interesting to see if that number is dropping where more and more employers are trying to measure the ROI. And then the value of investment. So this one, again, is a little different than the return on investment and gave a little more detail. And there's a lot more detail in this book too about how you measure the value of your investment. So there you're looking at things like fewer safety incidents, the ability to attract and retain top talent. And one thing I think when we see people negotiating pricing, it's harder to think about this up front when you're negotiating a new contract, but especially when you're in that renewal term, or you've put your everything out to an RFP, it's a little easier to think about the ROI versus the value of investment. And both Larry and Mike, I don't know if you guys have any comments on those concepts or want to jump in here and how that impacts pricing and thinking about guarantees and everything.
Well, I would only suggest that when you contract with someone, if you're an employer, you ask the vendor partner what their standard reports are so that you can take a look at it and see if it's useful for your purposes. If you're a vendor partner and you're contracting with an employer, you want to ask what reports can you get on a reliable basis so that you're not in a position 2 years down the line to say we tried to get this for the last 23 months and could not. So there's an open discussion and dialogue. Maybe you're not measuring ROI the way that I would, or maybe you're not measuring VOI the way that Larry might, but you're measuring something. You've got to get some measures in there that both parties agree upon will be good markers for continuation of contracts and for judging effectiveness. So I love ROI. I respect VOI, even though I see it's a little bit more challenging to discuss. But to not measure anything is going to cause disaster in a program 2 years down the line when you've got a new CFO and you've got a contract renewal. So the source book that NAWHC published is really a good guidebook for discussion, should be thrown on the table early on in the process so that both parties can take advantage of it. It's not one or the other. The pricing process should be a collaborative development type negotiation, not a flea market type of negotiation.
And many of these areas can be included into the performance guarantees that you develop in the contract as well.
Absolutely.
Yep. Yeah, and actually, Mike, a good lead in here, I don't know, maybe you did that intentionally, but you talked about what's the reporting the vendor will give to you, but also what information can the vendor get? When I've been on the vendor side, I've seen that as an issue before where we're supposed to be doing this reporting and giving metrics, and frankly, they can't because they're not able to get good data. And whether that's because there may be we've seen instances where other third-party vendors are involved, like a TPA or claims data, and we're just having trouble getting our data sharing agreements, in place to get the data, or they, aren't willing to give it. So having that open discussion about what data is available, what is the data flow, because sometimes these data flows will get incredibly complicated with data being shared among 5 or 6 parties. And what agreements do you need to get there? Like the data sharing agreements or the DPAs or your business associate agreements are going to be really critical. So to really get that good guarantee information, you need to think about the core reports. And, some of the ones that came from the guidebook are just utilization of the center and referrals to provider and hospitals. And that was what Mike talked about earlier, is a really easy metric to look at is emergency department visits and hospitals, the drugs prescribed by frequency, type, and cost, EAP referrals, financial reports, the biometrics performed. This is one I've seen an issue with where we had an instance where on-site clinic vendor was supposed to be doing 4 or 8 or however many biometric screenings a year and wellness fairs. They were available to do it, but the person at the employer, their liaison, was not getting it scheduled when we wanted to do these wellness visits. So we were having trouble getting it scheduled to do what we needed to do the reporting, so, just that communication piece. Risk factor identification and clinical improvement, the preventative services performed, And then there's a few others there. I won't read those all to you. But again, core reports for any centers. And then the guidebook also had the reporting that we could expect for new centers and some other details in there that were really helpful too.
I would say that if you're looking for a metric that's basic to everything, it's the employee engagement rate. More employees involved in the center will absolutely be better all the way around for everyone. Program participation, however you define that. Biometrics performed means that you've got to do a baseline before you develop a biometric model. The financial report should be easy. The rest of the stuff, very, very difficult and challenging. Sometimes the utilization and referrals to providers and hospitals becomes mired in HIPAA. So it's so important to sit down and say, what can we get? And how are we going to be able to use it in the future?
Yeah, and I would comment that for new centers, you may not have a lot of data in the first year or so to be able to measure many of these areas and have reporting. So you have to look at the data that you have available, and then what were your objectives, and see what can you report on during the first year, during the second year, and then what you can as you get more mature and you have a much more treasure load of data available for you.
Yeah, completely agree. And Mike, I'm going to turn it over to you now, if I could get the slide changed, to really talk about the differences in pricing from on-site versus near-site shared clinic, and to also then look at some of the modeling that the LaPena group has done in this area. So take it away, Mike.
I've got a very simple 2x2 matrix here that on the next page that addresses on-site versus near-site versus shared clinic. Remember that an on-site clinic is very easy because we just have an on-site clinic. We have it down by the gate where people come in, or we have it in a part of the school. But we may have a near-site clinic, and a near-site clinic, if it's owned by one employer, is very simple. You may have to allocate costs between a couple of different buildings or a couple of different divisions, but allocation of costs internally is not a problem. You just allocate it. But if you're working between a couple of employers or a couple of school districts or a county and a city on a shared clinic, it becomes a little bit more, complex, but not that complex. This is just a two-factor issue, which talks about the capital and talks about some sort of process measure for utilization. And the capital, the whole program costs $5 million over on the far right, and the capital for employer A, B, C, D, E, F, and G, everybody pays for their own capital. So somebody got off light, employer number D, and then a couple of them had more expensive capital allocations. That's not a problem. And then you have a variable, maybe that's number of lives covered, and another variable, the process measures, how much is utilized by the lives covered. So you've got a per life, could be per employee, could be per utilization indicator, like how many medical records we've got. And then you've got actual process measures. So all you do is take a simple spreadsheet, agree beforehand on how you're going to allocate costs, and then something like this on a quarterly basis or on an annual basis or every 6 months allows you to allocate those costs in a very fair and proportionate fashion. You can also make this more exotic by saying, gosh, we want to weight these different areas. And weighting is something that moves it from the total objectivity of a spreadsheet to the subjectivity of quality, value, or intensity. So you want to do a shared clinic, there's a pricing example. So let's move on to the next level. If there are cost allocations that pop up, you can also add different things. If someone's got physical therapy, if somebody else has peds and someone else doesn't. You can put all of those things, I feel, into a spreadsheet and make it as simple as this or as large as a garage door. But you agree upon it beforehand, and then that's something you can usually take to your board to use for your allocation purposes. Again, if anybody wants copies of any of the material that I reference, or I'm sure that Stephanie might reference, and certainly Larry has an open library for all of us, then you just need to contact one of us and we'll be glad to share it with you. But how do you price this stuff when you're sitting at a table? I guess that's our next slide.
Yeah, actually, before we jump into that, Mike, I'm going to jump in here with intersection of billing and pricing. Probably should have put this up above. A quick comment here, just think about the involvement of your third-party payers, whether it's a self-insured plan, if you're that, or you were actually working with, an Anthem or other third-party payer. We are seeing a lot of the on-site clinic providers, and of course the health systems, the on-site clinic providers too, really start utilizing CPT codes, which can give you some really nice data and metrics. And then I just wanted to make one comment, because I've seen this come up multiple times now, is thinking about retirees. And so I think this is something that people don't think about when they start a new clinic, but they need to be thinking about, is if you have a person who uses your clinic for 8 years, loves the provider, retires, goes on to Medicare, and wants to keep seeing that provider afterwards at your clinic, if that provider is enrolled in Medicare, they likely cannot see that retiree because they're not going to bill Medicare for that visit because the clinic is not set up to bill Medicare. So you usually have to exclude the retirees, or you can use Medicare opt-out providers. But I have just seen it come up now, and thinking about, how you're going to bill and price that is kind of an afterthought when you have that, 1 or 2 retirees or population that loves your clinic provider. Okay, Mike, sorry to jump in there. Back to
No, but that's
pricing issues now.
That's an excellent point. I would only say that the internal, external billing audits, turf that off to the vendor partner and make sure that you're included and your counsel is included in the reports. On the repayment obligations for overpayments, that has a implication for whoever's there taking the money. We always make some reference to the exclusion of Medicare beneficiaries. And we make the statement right up front. We say, we're not doing this for Medicare beneficiaries. When they retire or move to Medicare, they're out. That starts the dialogue right up front. So that gets the HR person to jump out of their chair and say, wait, we need some sort of mechanism to take care of people who may want to stay on our program, but go from our insured product to a Medicare product. So that's where your TPA, your HR person. So this is an important slide to reflect upon. Again, when we're structuring something, we just make the blanket statement, which we always know people will brace back against. CPT codes, we'll talk about work RVUs. We would always say that everything needs to be reflected by a CPT code. That's the only transactional, basis for judging behavior in a medical clinic. And it always has a standardized understanding across all platforms. So an important slide.
Yeah, and Mike, I would just echo what you said. If there are vendors on the line here, put that in your contracts that you will not see Medicare beneficiaries right up front. So 10 years down the road, when you're still working under that same contract and you've had a certain part of the population retire, you can go back and look at that, because it's going to be a nightmare for you and your providers if Medicare beneficiaries start slipping in and you were unaware of that at the time of treatment and billing. So just really important. Mike, good point on the contract. Okay, go ahead, Mike.
Pricing methodologies, and there are combinations of all of these. You can do a cost plus with a pass-through of fees. And what that is simply, we'll do whatever you want to have us do, but it's going to cost you that plus 10 to 15%. We pass through all the different fees to you, and we're merely a manager like an MSO. Then you could do a cost plus without pass-through of fees, where you trust the vendor to develop, the vendor partner to develop a budget, and then you agree upon either a monthly fee or a per unit fee, but it's all goes back to a cost plus model. The cost plus model is useful for these two first points because it forces everyone to take a look at what the costs are of a event, or how the clinic compares on a make or buy basis. A make or buy basis is, can we make it at home cheaper than we can buy it in the community? The unit pricing is to segment different parts of the healthcare event and price it out on a unit by unit basis. So if we have a very robust population and we've got maybe a captive population, and we can control the flow of patients through the clinic turnstile, then we might price it like a fee for service type thing, unit pricing, transferring the risk of provision from the cost of the employer through a healthcare benefit plan to the cost of and potentially profit of the vendor partner. So unit pricing is pretty straightforward, but it's a risk model that transfers cost from the cost risk from the employer to the vendor partner. What else have we got here? I'm sure risk, startup fees, and management fees. The startup fees are, we see in most contracts, a ongoing pricing structure and a startup pricing structure. So a firm may come forward and say, gosh, we can, for a 3-year contract, we've got a certain amount of startup. So it'll be $400,000 to $500,000 for the startup. And then on an ongoing basis, this is how we're going to price it. The startup fees generally relate to something that Stephanie reflected upon: recruitment, intellectual property, relocation of resources, perhaps equipment and placement of equipment, licensure, things that happen in the first 2 or 3 months of development. Management fees on an ongoing basis are generally incorporated within. Incorporated within is a different way of saying hidden, or they're very basic, like our cost plus or at cost with pass-through fees. And the management fee structure, it can be described a number of different ways, but we look for it to be 10 to 20% if we can figure it out based on our, spreadsheet. And that is what we would what we would see as a starting point for discussion. So startup fees, management fees, we try to put those into a spreadsheet. We don't want to have anybody in a project in which we're involved start or initiate an on-site clinic or any kind of healthcare service and then have to take it apart in a year or 2 years because people weren't managing a proper business case. So if you think management fees are egregious, do it yourself, because these things are very, very complex to start up. PMPM, or per employee per month. The different pricing strategies from the previous page can be reflected in a lot of different ways. One way is we will have a charge per employee per month or per member per month. What's a member? Well, if a spouse comes in and enters the clinic, they may not be a employee, but now they're a member of the clinic. We want to have dependents involved, I feel, at least, because if you're covering their healthcare costs through a dependency contract of some kind with the employees, then let's try to control their healthcare costs as well, and their healthcare quality, and their healthcare indices, or their health wellness indices. So PMPM, or per employee per month, kind of sort of like an HMO might get paid, but translated into employer provider partner contracts. Once you've got a budget, you can display pricing in a number of different ways. But now let's talk about.
And Mike,
go ahead.
I was going to jump in on what you talked about, a member too. You know, when we're thinking about the PEPM model, I always remind employers to think about ERISA compliance and benefit design, because a lot of times when you're talking with the TPA and the brokers, they think of members as those that are eligible for the health plan. And so you're going to want to think about, you know, is eligibility group broader than employees, or employees and family members enrolled in the group health plan? And really the safest design is to offer the clinic only to participants on the health plan. And so, you know, just thinking about the ERISA and the plan design compliance here, when you define the member versus just your employee, can be a really critical factor to work with your benefits, you know, and HR team there.
Right. Well, you get into the whole idea of whether or not you've got coordinated benefits with a spouse, and whether they can use the clinic or not. The idea, I believe, that is a distinction. If you've got a clinic and it's a patient-centered medical home, is my medical record held at the clinic, and are they managing my care? In the SpaceX One Medical example, they were talking about overarching care of the entire employee, a very, very sophisticated model and a very effective model. Traditional fee-for-service is turnstile through the door, pay as you go. Somebody comes in for a procedure or an encounter, and there's a fee for it. That's less less used in contracts related to on-site models, unless there's a vendor that is urgent care or telehealth. Fee for service with a risk component, that's the combination of PEPM with some sort of risk indicator, or the fee for service coordinated with some other guarantee or metric that allows rebate, or I almost said the word kickback. Sorry, Stephanie. Rebate.
Don't say that.
I know it. Performance guarantees and performance incentives. If you can't measure it, you can't have performance guarantees or performance incentives. So if you haven't measured it on the outset, the ones that I think go back to the original slides that Stephanie offered, emergency department utilization, very easy target to understand, to count, to hit, to augment, to reorganize. And so if you want to start with something, start with emergency department utilization, urgent care utilization, out of network utilization, and you can then go beyond that to incentives that relate to hospital bed day uses and inappropriate or extravagant admissions. Very easy to look at. I think a lot easier than healthcare maintenance indices. But
Mike, you mentioned out-of-network concerns. Do you recommend that the clinic and the provider that the employer use become a network provider within the employer's umbrella health plan?
I do, but that's because I imagine the clinic being part of a referral network, and understanding the fact that there has been somebody who's been smart enough to determine where urology should be seen, or dermatology. And if the clinic is effective, it's channeling people toward specialty care that's appropriate. So if you have expensive dermatology and effective dermatology, which means immediate access and not necessarily inexpensive, but accessible, that can save tens of thousands of dollars. Easily channeled, easily understood, easily measured. Um, so, um, so the answer is yes, Larry. I think that in-network is important.
And one issue we've seen in contract negotiations with that too is just the lead-in time. So if you have an on-site vendor who's traditionally not used to having to do the credentialing to get in network, that can take months at times. And then there's, different billing guidelines and audits, and it really triggers and kind of opens the door of new issues. So I absolutely agree. I'd recommend it. And we see that more and more, but especially, if you're a vendor, just be thinking about, you want to open your clinic on this date. If you want to be in network, by that opening date, there's a big lead in time for that credentialing process. And sometimes it's not always very straightforward.
The employers are commercial employers. They've got a lot of power, and we've had employers go to their carrier and just say, look, as of December, we're out. And so because you have such a strange, bizarre, long lead time credentialing process, and you're giving our vendor partner a hard time, we're going to rebid. And that brings the people from corporate immediately to the table. And so I would say the vendors and the employers have a lot of power in this contracting process. And the vendor partners need to learn these tricks. Shared risks, let's just take the emergency department. We did one recently where it looked like we could very easily save $1 million every quarter on the emergency department. $1 million. And we talked to the employer, and the employer said, totally impossible. We can't control it. We've tried. We talked to the vendor partner, and we said, why don't you take 25% of that as your shared opportunity? And sure enough, emergency department visitations went down. Why did they go down? Because the vendor partner made sure that people had access almost immediately to their services. If you go back to that original presentation that Stephanie started this with, they listed the emergency department costs as one area of effectiveness. Full risk, we see that seldom, but it could be done with a hospital and a healthcare system, where the hospital or healthcare system recognizes that partnering with a TPA and with perhaps an insurance product, they can bring full risk contract to the table. Very attractive to an employer that can understand full risk. We've done that probably 3 times in 10 years. So I don't want to say that this is very common. The vendor partners and the vendor partner community is not structured to participate in full risk. And those who are involved with venture capital and private equity have no interest whatsoever in that model. Carve-outs, telehealth, specialists, pharmacy. I would also put physical therapy in there, physical therapy and rehab. And then you might have some other specialized services, EAP, et cetera, where you want to carve them out. And if you sit down at the table and carve these out up front, I think the best example is telehealth. No one anticipated through COVID the impact of telehealth and how it might change the nature of primary care, change the nature of access. So nobody carved it out. It just wasn't on the table. And therefore, telehealth became something in 2020 that all of a sudden cropped up as an adjunct, a brand new service that was necessary for people to consider adding on. And I think that's part of the discussion about contingencies. A couple of discussion points for pricing. You want to vet your vendor. I guess we always think that the vendor provider community is homogeneous. It is not. Perhaps a regional vendor might be more important if you're going to work with hospitals and healthcare systems because that's all regional. Or a national vendor might be more important if you've got many different sites across the nation. You would have a master contract and then perhaps subcontracts. So if you look at the vendor beforehand, you do some background on the vendor, you're going to be able to figure out what type of pricing process you're going to want to take with that vendor or what you can expect from them. On the RFIs and RFPs, you can ask for material regarding the pricing structure, the pricing model, which is preferable to them. And the vendors can also understand where they're going to have a problem contracting with someone. Because again, as I mentioned, the pricing process is not a flea market, and different organizations have different parameters. Good to find out in the RFP process. Full transparency, if someone can't offer full transparency, that means immediately you think they've got something to hide. Maybe not. Maybe they've got a contract which requires them to maintain confidentiality and non-disclosure. That happens in pharmacy all the time. Love to have full transparency if you can get it. Market-based research, I believe you're doing that right now, but there is a lot of market-based information around about what different vendors charge. And I think what you might do is to go to your NAWHC programs, and you're going to be able to find out a tremendous amount just having lunch with a bunch of people of like interest. And that's where vendor partners, people who want to serve the industry can find out a lot about what employers want to know and how they want to price their stuff.
Michael and Stephanie, is there a broad range between pricing of vendors, or is it pretty close? And also, is there opportunities for negotiation, or are the prices pretty well set?
Well, I'll comment. There's a narrowing range, because if you start out with the employer's total cost spend, they've always got the ability to take all their dollars, put it in a pool, divided by the number of employees, and then come up with a cost per month, cost per year. So the vendor has to fit within that. They can't add $20 to $50 per employee per month and claim that they're going to be able to save that. That's a very unrealistic expectation. So I would say that there is a narrowing range, and is there flexibility on how to price these things? Yes, guarantees and risk models give opportunity for people to have a robust dialogue around fee schedule development.
Yeah, I would agree with everything Mike said, so don't need to repeat that. I would say where I see more of a broad range is I still work with some employer clients that manage their own health clinic. And so, I really liked Mike's comment earlier, if you don't like the management fee, well, you've got to manage it yourself, and it's really hard to do and very challenging, but it can be done. But if you're going to do that, you also have to think about, the staff that will take on the employee side that's going to really need the expertise and the time to do that. You can't have someone that's like your full-time HR rep, also trying to manage and handle the on-site clinic. So that's one area that we, of course, see broader discrepancy in. And I would say, if you're managing your own clinic or working with maybe a on-site clinic vendor that's not as established, you might have more control over your subcontractors. And through, and actually it's the next point. So through managing your own clinic or really demanding that transparency and understanding the subcontractors, there's also a lot of different pricing, and I think more variable pricing once you get down to more nuanced areas. So like the telehealth, the chiropractic, the physical therapy, the EMR or the EHR company that your on-site clinic vendor utilizes or that you do. So, not that cheaper is not always better when it comes to subcontractors or on-site clinic vendors. Sometimes you pay for what you get, and you need to really look at that. But I think that's where I see more of a range to think about in the pricing, but also, what's the end result of the services you're getting and the amount of work the employer will actually have to do then. So Mike, I'll let you jump back in here.
Yeah, yes, I agree with all of those points. I will say, again, because this is an inside group, the few times that we've been asked to assist with development of an on-site program for an employer that wants to do it themselves, we of course will give them a projected cost for our services, legal, accounting, a few other things. And then they'll always say, no, can't do it, too expensive. So we say, well, have a good life, good luck. And, here's an outline you want to go through. And then we suggest, Larry, they call you and join NAWHC. But then in every case, we get a call 4 months, 5 months later saying, we're reconsidering. We'd like to have you help us because they hit a wall and they just don't know what they don't know. So the vendor partners who have done this before bring value to the table.
Mm-hmm.
That's what I would stress.
I absolutely agree with that. I would say too, where I've seen it be more successful is on the occupational health side. I do see more employers manage some of their own occupational health clinics with a medical director, and they'll still contract out to vendors, but they're actually managing it. I have not seen it on the primary care side nearly as much where, it's really been a good long-term solution, although it definitely can be done. That would be my thought on that.
Yeah, it can be done. I don't want to. Occupational health is rather one-dimensional, and it's very much bound by regulation, and it's state by state definition. So you have to hire somebody from within Texas to manage a Texas health clinic. So I get that, but the primary care is a complex model. Understanding ROI, I don't think that, I think we've beat that to death. If we look for locking in a price, I think we all learned through COVID that locking something in as, there are several different changes that can occur. Sites can go into production, out of production. Employee levels can change. Even school districts that seem stable had to renegotiate on-site clinic contracts this past year. Renegotiation of price at renewal, even on a long-term contract. Sometimes you'll have a longer-term contract that calls for price renegotiation midstream. I would also say that some of the firms we've worked with have their own pricing or their own purchasing rules and regs, which require things to be rebid at certain points in time. Think of large manufacturing auto firms that, have a very, very strict purchasing policies and departments. I think the next part, Larry and Stephanie, I'd ask that you guys weigh in here because this is a complex process that deviates from pricing and goes into costing, and how HSA and and the fair market value process that, Larry, you've been working on behalf of now the last 2 years or 3 years.
Yeah, I'll
So
jump in with just
go
a
ahead,
little
Stephanie. Why don't you
Go ahead.
introduce that?
Okay, I was just going to jump in with a little background, and then I definitely want Larry to chime in here with all the work that he and NAWHC has been doing on this. But basically, if an employer's plan is qualified as a high deductible health plan, you really have to take steps to ensure compliance with IRS requirements. And what's interesting is I'm probably more on the vendor side, to be honest, although I do represent some employers too. And I would say vendors are very concerned about this issue, even though it's the employer's high deductible health plan. I think for two reasons, because it can impact pricing and the vendor. the legal framework here and how to price this. But basically, employers must charge fair market value for non-preventative services for employees with high deductible health plans and HSAs. And so it's really kind of a tricky issue from an on-site clinic standpoint, because as we saw from, I think it was a SpaceX example, most on-site clinics do not charge anything to their employees. And so I'd love Larry to jump in here to talk about what that fair market value we believe is and should be, and how the IRS would view that, especially given that there's not a lot of guidance on this issue. So Larry, if you want to give a lot more detail here, that would be great.
Sure. So we've done surveys of members, and we've worked with our partner Mercer, and they're looking at the same issue. What we find is that the requirement, which is in the IRS code that Stephanie mentioned, does not define what that level of mandatory copay will be, that fair market value charge. And so we have members who had charged as little as $10 and as much as just below the network provider fee or the Medicare rate. As long as you have some documentation showing that you've looked at this in your community and this is what you intend to charge, there has never been at this point a charge or penalty against an employer that either we found or that any of the consultants or attorneys we work with have found. So as long as you've got something, it's important to do. Unfortunately, our surveys also show about 25% of our members aren't charging any fair market value charge for any of their services, even with their HSA people, because they believe their clinics are only offering preventive or wellness services. And it's very problematic, I think, because the way the IRS is defining on-site clinics, it's essentially a triage center for first aid. And now there are listings of preventive services you can offer and maybe some chronic disease, but you're really putting yourself in jeopardy if you don't charge some fee. And so it's important that you talk to your attorneys or consultants or just internally or with your vendors and providers and identify what that fee will be. NAWHC is in the process of creating a fair market value collaborative of employers and vendor partners and providers to try to repeal this provision in the IRS code. But it's a long-term process. If you're interested more in that, get in contact with me. I'll turn it back to you, Steph.
Yeah, Larry, and one thing too, and again, this resource is available, but the 2018 survey report that was done by NAWHC and Mercer had some really interesting statistics. They talk about how where you had clinics that provide more than just the preventative services that Larry talked about, which is frankly most on-site clinics, who also had HSA eligible plans. About 13% of the survey respondents said they don't charge fees to members who have HSAs. Although, again, I would definitely recommend that you do charge some type of fee and have the documentation to support it. But, they talk about how most often the clinics are using an allowed amount fee schedule that's consistent with either community charges or some type of discounted schedule. And then there's a few, about 13%, that were determining the cost of a visit based on the clinic operations, and then about 7% using the Medicare fee schedule. So as you'll see, it's really all over the board there. And I agree, you just need the really good documentation to support it, but I've not seen any IRS enforcement actions on this issue. And we try to stay pretty up to date because it's a question we get, I don't know, every few weeks. One other thing here is you'll just want to think about COBRA implications. Basically, does someone who is no longer with your company have the right to utilize the clinic under COBRA, or how are you going to manage that? So again, just really being thoughtful on the plan design and working with your benefits attorney and in-house benefits team on these issues is critical. And I would say, employers, this is one of those really big diligence items where get on top of this from a benefits and plan design perspective before you even start contracting with your vendor. So you're able to give them guidance on, even from a workflow perspective, for example, if you have to charge that fee, how's that being done? Is it, being charged when they walk in the clinic? Is it being charged separately? So thinking through all those issues is critical. And I think this is our last. Go ahead.
I'll just give you one other idea. I'd welcome your comment on. For fair market value, we do a lot of fair market value stuff for OIG and CMS purposes, not really anything for IRS unless it's enormous. But when this stuff came up, we contacted the IRS or officials, enforcement officials, through one of their attorneys, and tried to figure this out. We couldn't figure it out. There's no answer. There's no rubric for it. But a couple of times we've had some employers say, what should we charge it? We just say, charge the prevailing Medicaid rate, because that's a CMS sponsored rate. It's recognized by the healthcare community. People go in to receive care at that rate. And that's the most modest rate that we could find. We were surprised by this SpaceX zero copay thing. I'm not sure who figured that out, but that's not fair market value. We always say.
Well, and that was interesting. That was zero copay for on-site, but 25 copay for near-site. So I thought it was interesting how there was even a discrepancy of the on-site versus near-site in the SpaceX, Mike.
Well, I think that's a consumer steerage issue. I can't be anything but they're just trying to get more utilization to their on-site clinic, I would think. Well, we always say charge something. You have to charge something because that creates a transaction at registration, so that it creates a discipline, and you just don't walk in and get stuff for free. So anyway, those are the only two comments that I'd make on that.
Yeah, one other thing about pricing is I have a client who they don't have an HDHP or HSA, so they don't have to charge anything, but they do charge a cancellation fee if an employee cancels like the day up or, within 24 hours. Now, they have some leeway if there's an emergency or something, they'll work through them, but there were just it was demanding to get a spot at the clinic. They were limited and they had too many people who just weren't showing up because they weren't at all vested. And so that was a great way to get people to really think through that. So just a few minutes left here. So Mike, I don't know if you want to hit on any of these other considerations. I think we've talked about guaranteed terms, but maybe, most favored nation clauses. I'll talk about that one quickly and turn it over to Mike. But this is basically where you tell your clinic vendor, if you're going to give any better pricing to anyone else, you've got to give that pricing to us too. I don't see that a lot on on-site clinic vendors being able to offer that. And if it is offered, a lot of times, there's some limitations around it where it's like, okay, we can do this for this regional area or for this size of employer, but we can't give you the same pricing that we get for an employer that's 3 times the size or vice versa. So Mike, any other thoughts on kind of the exclusivity or role of the broker and TPA?
Well, 2 or 3 comments. The most favored nation clause can be used against you also when a hospital or a local ancillary group has made a commitment to a HMO or an insurance company that they'll give you pricing, that they'll give that pricing. And I always go to the most favored nation clause and say we want a dollar per visit proximity to your most favored nation pricing, because people will use that as a strategy in refusing to give you their best price. Exclusivity clauses, if you are developing some sort of region-wide opportunity for near site or shared site, then you want to tie your vendor to some sort of exclusivity so that primacy and priority is given to the first employer in, and that goes both ways. The guarantee terms, a lot of times that relates to the initial setup. We will have it up and running by September. You don't need to have any concern, and all of a sudden somebody can't get a medical director in or can't relocate staff or guarantee the availability of the guarantee. I think goes hand in hand with construction. We have construction guarantees all the time, but vendor performance guarantees less so. We always put that in. The broker and the TPA, they'll immediately want to become involved in the pricing construct and the development of contracts. They've got the opportunity here, brokers and TPAs, to be really replaced by the on-site vendor partner. So if they don't come to the table with value, there's a new person in town, new sheriff in town, who's reorganizing healthcare, and that becomes a big threat to the broker and the TPA. Sometimes we've gone back to the broker and the TPA and asked them to give up part of their margin in order to allow us to do an on-site program. And that's worked. So it's another channel or opportunity for constructive redesign of the healthcare system. So those would be my final comments. And I think this is a robust topic, and I hope we've covered it and given some of the attendees some ideas. Oh, transition.
I just realized I forgot to hit that one. Sorry.
Yeah, no problem. Yeah, I don't even. Let's have a whole 2-hour seminar just on transition. It's a real problem. You can't transition easily, and you can't transition unless you planned on it.
What we're going to do now is to go around the table of those who are still on the call, getting questions for Stephanie and Michael. I'm going to go through the names here. Some people have listed just their phone numbers, and I can't call upon them unless I know your number, but we'll start at the top. So I have BG. Do you have a question or comment that you'd like to make? Okay. I'll move on. BJ, do you have anything you'd like to do? If not, we'll move on. So Emily Starleaf, you have a comment or question? Emily?
I don't have anything. Thank you.
Okay. Juliet Chotlin. Juliet, any comment, questions?
Hey, how are you?
Good.
We
Any comments or
here was one
questions?
of my cohorts, and we were thinking about some of the costing and the modeling. And when you talk about the cost plus and your billing insurance on the back end, I mean, is that considered a hybrid model? Are you charging that cost plus, that plus piece? That's an administrative cost, and then your billing insurance. We're just kind of looking for some clarification on that on the back end here.
Well, I would call it a hybrid model. The front end costs can be pretty well defined, and then the ongoing management costs shouldn't be much more than 10 or 15% above what the reported costs are or the verified costs. On the back end, I'm not sure if you're talking about the costs for specialty care and hospitalization. That's generally outside the model of the on-site program.
Yeah, and this is Stephanie. I've seen it when you have on-site clinic vendors that do have providers that are in network, where they still have the per employee per month or per member per month, if it's employees and dependents, that they bill, and that really encapsulates the management fee. So you'll want to look at what that is, over the course of 1 year and how that's broken down. But then they're still on the back end billing. So I've seen it done both ways there. So yeah, I would agree. It's probably a more proper term, like you said, Juliet, is like a hybrid model then.
Thank you. That's very helpful.
Megan Schmidt, any comments or questions?
No, thank you so much. This has been a very good presentation, and I am looking forward to getting the slides and rewatching the presentation later.
Okay, thank you. Melissa Przinski, comments or questions? No, okay. Sheila Schneider, any comments or questions?
Hey guys, thanks so much. This was really helpful. So out of curiosity, we have, you talked about the Medicare and Medicaid rates for the fair market value. Is that something that, Larry, you can share out after, or a reference web page to look at? We've just been looking at some of our sites we charge, and then some we don't charge, and we're just kind of reviewing that right now. So I think that would be helpful.
Yeah, so we have a presentation that Mercer did with their study of employers who use HSAs with their clinics, and I'd be glad to share that with you. So I'll send that along to you afterwards, as well as some other materials that we've got. Be glad to help you out.
Yeah. If you dig around on the CMS website too, it's not easy to find, but you can get to different Medicare fee schedules. But I'll just caution you, if you haven't looked at that before, there's like tons of different ones and they vary and everything. So if you're looking at the Medicare fee schedule, you'll have to take some time to dig through CMS. So I would say do that absolutely in conjunction with what Larry will send you, because it'll help streamline a lot of that.
Right, but I'll short circuit it, I guess, a little bit. There are only 70 or 80 codes that internal medicine or family practice operation would use out of the 6,400 codes. And so that's the stuff that goes through an on-site clinic. And you can get those. We'll send you a list of them if you want. It's easier than going to the CMS website, because I think what you're asking, Sheila, unless I'm mistaken, is what do we charge for a visit, a 99,213 or 4 in our clinic based on Medicare. The Medicare fee schedule is a national fee schedule. And if you're in Pennsylvania or, I don't know, Michigan or something like that, Medicaid is much different. So.
Yeah, and I think those CPT codes are in that Mercer thing too. That's such a good point, just to look at those, not like all of them by any means.
No. But CMS website, you'll look at it and just go blind.
I appreciate that. Thank you.
Yeah, just send one of us an email and we'll send you the codes.
Okay.
Are there any other
Thank you.
questions? Sure. Anybody else on the phone that we've or in the program that we've not called upon? How's your opportunity? So again, I've got some people who just listed their phone numbers. So I can't call your names. Anybody want a question? If not, all right. Well, at this point, then I really want to thank Stephanie and Mike for a wonderful presentation and great time to be taking the time to pull all this stuff together. As I said, this recording and the slides will be available to everyone, and for members, it'll be on the website. Mike, they've asked that we give them the CPT code list that you've got. If you want to send that to me, Mike, we'll send that out to everyone. And again, I'll have the HSA study that we did with Mercer, and we'll package that all together for people who've been on the call. With that, I want to thank you all for, again, taking time today. Hope to see you at the September 9th and 10th annual forum in Chicago. Otherwise, we have some other programs coming up. In fact, we've got a new session program on August 17th on the impact of COVID on childhood and adult wellness programs and vaccinations. It'd be interesting for those who would like to see that. So again, check our website and our mailings. We'll see you soon. Everyone, have a great week. Stay safe. Bye-bye.
Hi, thank you.